So just to introduce ourselves, I'm Ben Heyworth, I'm the survivorship lead for the Christie, and this is Martine, who works with me on the team. This is Sue Taylor, who some of you will know from the patient reference group, who's representing our patients today, and has been heavily involved from the get-go around designing the Life Ahead plan and lots of other stuff with the survivorship agenda. And this is Sandra Rowlands, who's come from all the way from Macmillan to talk us through the recovery package, which is the backbone to the survivorship agenda, and we're going to start with that.
Okay, and thank you. I'd just like to say thank you very much to Ben for inviting me today, and it's an opportunity to talk a bit more around the recovery package and survivorship and basically why we're bothering. You know, so I'm going to give a little bit of background of why the survivorship agenda is so important, and also how the recovery package is going to give us a bit more of a framework about how to do that more effectively and support people living with and beyond cancer. And you'll notice that I use the more long-winded version of living with and beyond cancer because the feedback we're getting from people affected by cancer is not actually like the term survivorship, though sometimes we say it's a quick way of saying it, but actually it's how we get people back into their normal lives, whatever that might be. So, without further ado, basically, we know the cancer story is changing, don't we? Those of us that are a bit older in the tooth, I'm a cancer nurse by background myself. I'm doing 2 jobs in Macmillan at the moment. 2 days a week to live sort of learning development management, the other 3 days a week is working on the recovery package and survivorship agenda. We know with the research that's been done that we've now got 2 million people living with and beyond cancer, and by 2030 that's going to be 4 million people. It's massive, isn't it? It's huge. Absolutely. I mean, it's great, don't get me wrong, that more people are living with and beyond cancer, but actually, how are we going to support all these people, and what does that look, and what does support, effective support, look like, you know? So that's sort of the challenge that we've got. And we know more people are surviving because we've got early diagnosis, more advanced treatments, you know, we're moving, I hope you agree, with cancer being from an acute condition to a more long-term condition. If most people live within about a year, chances are they're going to carry on and be living quite a bit longer. And I'm sure you've seen that in your own practice. Now, so what's different about how the pathway is going to develop? This is the pathway at the moment. So you've got the purple, which is diagnosis and treatment, and then rehabilitation, the green. And then you've now got early monitoring and later monitoring, and progressive illness and end-of-life care. And can you see that actually diagnosis and rehabilitation is going to get a bit bigger, and so is end-of-life and progressive illness, but can you see the huge difference and increase in the numbers is going to be in that early monitoring and later monitoring phase? So the way we provide healthcare services for people affected by cancer has got to change, because actually the more people are going to be in this later monitoring, you know, the early and later monitoring phase, it's going to be quite a bit different about how we support and develop services to support these people. You know, not everybody's living well, let's be honest. You know, we've got 1 in 4 people affected by cancer who are living with the long-term consequences of their treatment. 1 in 2 cancer patients have got comorbidity, partly because we've got a more elderly population. You know, much of the media would like us to believe that most people have got cancer, young women with breast cancer, 2.4 children or whatever it is. Actually, we all know, don't we, the majority are over 60 and have got other long-term conditions as well. And 1 in 5 breast cancer patients face the recurrence of their cancer. But not only that, we know that people with cancer are 37% more likely to be unemployed. You know? They don't return back to work within the first year. They're very unlikely to return back to work at all. It's not just the actual physical impact, is it? It's that psychosocial, whole person sort of effect it has on their lives. And we know that more than 1 in 5 people are suffering with loneliness. And if you look at the recent figures, about 75% of people who have cancer have got some element of depression. Not surprising, is it? You know, it goes hand in hand, doesn't it, with the loneliness and depression. But you know, by and large, for most of the tumour sites, breast, ovarian, breast, lymphomas, you know, testicular cancer, we're getting really good survival rates. They're increasing. But unfortunately, just for some of the tumour sites, for example, esophagus, brain, pancreas, we know the story's not as good, and we've got a long way to go, haven't we, with these? I mean, I don't know if anybody works in those areas, any specialist nurses in those areas, but we all know, don't we, for example, lung cancer. We're not actually getting that much better, if the truth be known. It's getting a little bit better, but not that much better. This is just showing the comorbidities. So, for example, people with breast cancer will have 4 and 5 plus more comorbidities. bit about the history. Why are we all here for looking at survivorship? Basically, for those of us who remember, supportive and palliative care guidelines went on to inform the cancer reform strategy, and they realised quite rapidly they didn't actually know how many people were living with and beyond cancer. So how can you plan care and pathways if you don't actually know how many people you're going to have in the system? So a lot of work went on and work streams were developed, and it was the great and good got together at Cumberland Lodge and actually started to develop the National Cancer Survivorship work streams, one of which the thing is the recovery package has come out of that. How can we support these people and what frameworks do we need? Recovery package is a framework that we can use. And for example, research showed Arms et al. That 1 in 3 patients have unmet needs at the end of treatment. So we're not supporting the people that we've got. We know there's unmet needs. I'm not going to go through all the documents, but if you are interested, the patient experience survey backs that up. It's due out soon, isn't it? The next one's due out this week, the next patient experience survey. And you can almost tell by trust who hasn't got an information support centre and who hasn't got a CNS within a certain tumour site. If anybody's ever looked at it, you can almost see. So, you know, one of them I would encourage you to, if you are interested in survivorship, if you haven't already seen this document, is to have a look at taking actions to improve outcomes. It's a really good, say, readable document. I think it's not bad, is it, Ben?
It's all right.
Yeah, not bad. So basically, the National Cancer Survivorship identified 4 priorities, and the recovery package was one of those. And I'll talk briefly about redesign and follow-up and physical activity and consequences of treatment. I'm mainly here to talk to you about the recovery package. What is the recovery package? It is a combination of interventions that together will help give us a more holistic patient pathway. Okay, and that includes holistic needs assessment and care planning, a treatment summary and cancer care review, a health and wellbeing event. And the idea being that these 4 things together, underpinned by physical activity and healthy lifestyle, information and support, managing consequences of treatment, are going to help people actually be able to more effectively self-manage. Okay, so it's how we actually make sure people have got those tools they need to go back into their normal lives, whatever that we talked about the new normal, what that new normal is, and for some people, actually better than it was before. It's not always dark and gloomy, is it? I haven't got time to show you, but if you do, Ben's going to send this link round. There's a really nice video around the recovery package and about patients and people affected by cancer's views on how they've been supported by the recovery package. So I think it's quite, and apart from the fact it was done before Christmas and all the people have got Christmas jumpers on in the exercise class, so it sort of dates it, times it a bit. I'm going to talk to you, you've all got the concerns checklist, I've just sent them round. Some of you will have seen the concerns checklist, no point in you've seen this, haven't you? But basically, it doesn't matter how you do holistic needs assessment and care planning in one sense, but it does help if you've got a framework to do it within. And Macmillan have done a lot of work looking at providing a framework, and this is the holistic needs assessment and care plan framework. The idea being is patients would fill it in 10 minutes or so before you saw them, and they would identify their concerns, not our concerns. Which, you know, so it's actually, and sometimes it's surprising what you think what they come up with, you know, it's not often what we think it is. And then the idea being then is you'd use the care plan as a framework to identify what's going to be done about those concerns. Okay. So I'm just going to pass that by because I know, Ben, you're going to be doing more work in the future, aren't you, around holistic needs assessment and care planning. So I just want to throw that out there, that this is a framework you may well want to use. But that's obviously into the strategy for the Christie strategy. If you are interested, and you are in the future, Ben will order these for you if you needs be, and that's appropriate. But basically they're on B Macmillan. So I will leave that with you. And I'm just going to skip through. Now, I've showed you the electronic version of that before, and basically the beauty of the electronic version is you can amalgamate the data. And what we found is the top concerns identified were fear, worry or anxiety, no concerns there, and no surprises there, exhaustion and fatigue, sleep problems, pain and eating or appetite. And then one other element of the actual recovery package is the treatment summary. And this should be done by the multidisciplinary team. So basically it is a summary of an end of a significant event of treatment. So for example, at the end of chemotherapy, the end of radiotherapy, the end of surgery, or any significant recurrence, you know, it's significant. And basically the idea being is that the clinicians in the MDT would give a summary, so it's diagnosis, ongoing staging, you know, DS 1500, significant potential consequences of treatment, and that's really important. So it's a lot different than a doctor's letter, dear Dr. Jones, nice to see you yesterday. You know, it's more around, actually, this lady's had, she's on hormone treatment, and she's also had Herceptin, so that might be that she may in the future have heart problems type. Whereas, why would a GP necessarily put 2 and 2 together? They've had Herceptin.
I don't think they do.
They don't.
On a lot of things, and we just had a thing this morning where a patient hadn't had a thyroid check for a number of years, and the GP hadn't. You know what I mean? So this would enable that, wouldn't it?
Exactly. So it flags it up. So if somebody's on long-term hormone treatment, they might get osteoporosis. Would the GP think of checking their bone density? Not necessarily. Why would they? Do you know what I'm saying? So it's to try and get that record. Now what happens is this gets sent to the GP and the patient has a copy as well. Really useful for them. Why do you think the feedback from the patients? When do you think they found it the most useful to have a treatment summary? For what?
When they go to see the GP.
One, great. Yeah, and that helps inform the cancer care review. One of the anecdotal data we're getting is they use it for getting travel insurance. And when they go to other hospitals, they haven't got to go through it all again. There's a summary of my treatment. That's what's happened to me to date. You know what I mean? Just as a top level summary. But for travel insurance company loves it because it gives them everything they need in a sheet. So it's just by the by. And I know that's going to be some work in the future around actually treatment summaries, I believe.
Yeah, well, some of you will know that Wendy's auditing treatment summaries amongst the clinical teams at the moment, and I dare say once we've seen the results of that, we'll think of a way to help people to improve matters.
It's a huge thing, isn't it?
Yeah.
As consultants, a lot of them, and they admit it, are dinosaurs. They've done their letters as they've done them for 20 years.
Yeah.
It doesn't tell the GP anything.
And the letter should be tailored for each thing you're sending a letter for. So if you're getting travel insurance, they wouldn't want to know a lot of what somebody else might need to know.
Consultants are still being quite paternalistic as well about, I don't want to upset the patient. The patient's upset already. They're just treated for cancer.
Yeah.
And what right have they not got to, you know? I mean,
they need that information.
Of course they do. They need to be able to get themselves back on track again. It's, you know, this gets me because they've managed their lives very nicely, thank you very much, unless they've had problems before this. Why suddenly just getting cancer doesn't mean that they're not able to...
It's like you're suddenly disabled, isn't it? It is like a disability, isn't it? Because all of a sudden you've got all these ongoing things.
And don't get me wrong, I'm not belittling the impact of cancer, I'm really not, but I do think there's something about actually this person has been able to self-manage beforehand, well hopefully, and how are we going to support them to get back into their normal, new normal without actually taking all their power. I could talk about that for a while. Let me move on. Yeah, but there's 2 formats of treatment summary. There's the doctor's letter template, and there is this template as well. So you know you may well trial either of those in the future. Cancer care review is usually done or should be done 6 months post-diagnosis by the GP. Again, to look at things of potential consequences of treatment, care in the community, anything they might need that's more community focused. Okay. But how can the GP do a decent cancer care review if they haven't had a decent treatment summary? You can see how they all dovetail into one. I don't know why. Oh, I know that's because I've got it into. And another element of the recovery package is health and wellbeing events. Now, health and wellbeing events can form different levels. They can be a generic health and wellbeing event, which actually would have some people speaking about, for example, diet and physical activity or whatever it might be, and then there'd be a general marketplace where there might be age concern, there might be the local gym, there might be some of the CNSs, you know, around, so people can actually go around to the tables. Now, Ben is organising a tumour-specific one, a prostate one. Could you mind mentioning that, Ben?
Yeah, well, I'm sure people know about it who are involved with prostate cancer here at the moment, and that's the 20th of November in the Education Centre, 12 till 7, and we're running it twice, and it's a huge piece of work.
Yes.
And that's all I'll say about it now.
But the idea being, if in the future, that you'll be able to stratify the pathway. The reason I'm saying that is, some patients or people affected by cancer will be more than able, with a decent health and wellbeing event, to self-manage. and not need to come back for follow-up appointments. Because actually, for example, at St Helens and Knowsley, they've got huge problems in their outpatients appointments at the moment because they've got lots of low-risk skin cancer patients. They're actually not really being very well supported in their outpatients because they're just inundated. And they're getting a 10-minute appointment with a registrar, or it's not satisfactory. They're going to bring those patients into a proper targeted health and wellbeing clinic where they're going to give them proper skin advice, risk of recurrence, recognition of risk of recurrence, really targeted. Now, to my mind, that makes far more sense than actually just, do you know what I mean? So then they can meet other people who've got similar concerns. So that would be part of that. And I'm not saying it's suitable for everybody, but it's about how you stratify that person and what is the best pathway for them. Okay? So I won't go in. But if anybody wants to read more about stratification and how to, it's a really good document, the how-to guide, and Ben's got a copy if anybody needs it. And that's just a picture of that. Physical activity, quick quiz. This isn't on Ben's quiz. How many minutes of physical activity should we do a week? Recommended levels.
You.
I think you can do 2.5 hours, isn't it?
Yeah, it used to be half an hour 5 times a week. It's now 150 minutes. Yeah. Over the week in blocks of at least 10 minutes or more. Now, why? Well, we know, don't we, that the evidence has shown that if people are more healthy, they're less likely to get cancer, and if within their normal BMI, they're less likely to get cancer. But actually, it's got huge implications. It can reduce the consequences of treatment if people, keep themselves physically active. It can reduce comorbidity, diabetes, for example. We know the research is coming out now, don't we, about physical activity and diabetes. It can reduce the risk of disease progression, but it actually can decrease the risk of recurrence. In breast, bowel and prostate, it can reduce the risk of recurrence to between 30 and 50%. It's huge. There's research, if you go on the Macmillan website and go on the physical activity webpage, you'll get the documents, there's for the evidence behind that, okay? But so it's now, I'm a chemotherapy nurse by background, and I'm guilty of saying, just rest, but actually, rest is not best. We actually should be, if people are fatigued, I'm not saying we want them to go, but we need to actually encourage have more positive messages about physical activity. Do you know what I mean? So there's more to it than, And Macmillan have got lots of resources and physical activity toolkits and things like that you can use to support that if you need to. And consequence of treatment. I'm not going to talk much about consequence of treatment apart from saying, if you are interested, there's Macmillan now have got quite a lot of documents that they're looking at how pathway redesign around consequence of treatment and trying to get more specialists involved in actually that, recognising it, and just some support line and things like that. So thank you very much. I'm sorry that was a bit of a whiz, but I wanted to just get over. So if you start hearing more and more about the recovery package, hopefully you'll understand more why we're looking at it and trying to roll it out as a package rather than just bits. Okay, thank you for your attention. Hand you over
Thank
to
you
the
very
lovely
much.
Ben.
Smashing that. Okay, so that's the background really, and the Life Ahead plan is not really officially part of the recovery package, but for all intents and purposes at the Christie, it does dovetail with different aspects of it, and I think it's one of the main tools that we're intending to use to help roll out different aspects of the recovery package, because obviously some of it is going to be harder to achieve than others. So you've all got sight of a Life Ahead plan, and you've all got sight of the training handout, and what I'm going to do is I'm going to talk through the training handout and refer to the Life Ahead plan as we go along. If you've got any questions, that's absolutely fine. Please do shout them out, and there's a little quiz at the end just to make sure everyone's got the message and that you feel comfortable in using the Life Ahead plan in the appropriate setting. Now, I'm not expecting anyone to go back to work this afternoon and suddenly start throwing them all over the place. Obviously, we need to approach it in a sensible fashion, but I think we are getting to the point now where we need to think about using the Life Ahead plan more regularly and trying to embed it into everyday practice across the trust, and that's, as you'll see from the training module, there's a lot of different ways that we could do that I want to explore with you today. So first of all, I'm going to talk about what the Life Ahead plan is. And if I tap my nose, it means there might be a question about it in the quiz later, so that's the one to remember. So what is the Life Ahead plan? There's 6 or 7 different bullet points on the sheet here that I think sort of encapsulate what we were trying to achieve with the plan, and it is ultimately a care plan for patients to complete about life after cancer, or perhaps living with cancer, although I should point out that the plan's not for patients moving into end-of-life pathways or terminal patients or patients at really high risk. It's not appropriate for them at the moment. There has been some talk amongst our colleagues around redesigning it for that group, but I think we're some way off doing that at the moment, and I think it's pretty obvious it needs a bit of a tweak, because it's got life ahead written in big letters on the front for a start off, so things like that would probably need to change. But at the moment it's a tool to promote and sustain recovery after cancer treatment is finished. That's kind of the headline. And an opportunity for patients to reflect on experiences and start planning for the future. So you'll notice when you flick through the Life Ahead plan, there's a lot of questions in there that are asking people to reflect on things that have happened to them, reflect on their treatment, how are they feeling about it now, what's changed, what didn't they ask at the time that they now want to ask, what seems important, and then moving forward in time, you've got a second period of reflection, which is 18 months after the first period of reflection, which is the red section at the end. So you could describe it really as a longitudinal care plan, because it does ask the same questions more than once but on a different time scale. You see as well when you flick through the Life Ahead plan that it's not giving anybody any answers. So what this isn't is an information resource, and you would need to give this out with, at the bare minimum, some conversation about self-management and where to find information out. But in an ideal world, we'd like patients to have copies of GP letters, treatment record summaries, Macmillan information booklets, and some knowledge that would enable them to go away and help complete their Life Ahead plan. And it may well be that when patients sit down to try and complete it, they'll actually formulate their own questions, and we need to provide resources to answer those as well. And I'll talk a bit more about that later on, about how we can do that without creating loads more work for people. A document which promotes the idea of living beyond cancer rather than being a cancer survivor or an ex-patient. And we've already touched on this in Sandra's presentation, the idea of not using the word cancer survivor or survivorship. That doesn't appear anywhere in the Life Ahead plan. It's all about referring to people either living beyond cancer, or it's people with experience of cancer. And those phrases, I think, have they're much more appropriate for the sorts of patients that will be filling this in, although obviously we will refer to things like the survivorship agenda when we're talking in the corporate world, or the NHS world, or however we want to put it. But it's not a phrase that's crept into the plan. A way for patients to communicate with professionals about their cancer journey outside of the treating hospital using a shared, non-medicalised language. Well, this is really all about the fact that this is quite a long-term document, so people are going to hopefully, and possibly in the future, use it electronically, but hopefully have this for quite some time, and certainly the red section is not to be filled in for 18 months after treatment's finished anyway. So you might find that people are turning up at Wythenshawe, or perhaps at their GP, or perhaps in some other healthcare setting where they're receiving treatment for cancer or perhaps a comorbidity, and hopefully bringing the Life Ahead plan along with them and saying, look, this is how I've tracked my journey so far since I finished my treatment at the Christie, and these are some of the issues. And even if they don't fill it in, if they've formulated those questions in their mind, that's absolutely fine. We don't want people to think this is homework to go away and fill it in. That's not really the intention. It can, they don't have to fill every question in. It's a prompt, if anything, to be asking the right questions at the right time, and not to be afraid of asking some questions that might be really difficult for people. A tool to help redress the balance between medical care and holistic care. Well, we've spoken about the holistic needs assessments earlier on, and how important it is to pick up problems before they become crises that are around holistic need, and I'm sure you've come across patients who have identified problems of that nature in day-to-day practice anyway. And the idea is that the Life Ahead plan gives people an opportunity not just to talk about the medical side of things, but to also pick up on those things too, and to seek help where it's needed. And as I say, when you flick through the plan, you'll see there's loads of stuff about that. For example, work and finance. There's some stuff about goal setting, and there's a very strong healthy living message that goes through the Life Ahead plan as well. So that's your smoking cessation and the physical exercise stuff, which we picked up a few moments ago when we talked about the recovery package. So that's the Life Ahead plan in a nutshell. Does that make sense? Great. Who has developed it? Okay, that's the next question. Well, those of you who know me will know that I've been knocking around for about 4 years at the Christie now, and came in post to do a project about pelvic radiotherapy in the early stages, and it was to do with can we help people with bowel and bladder problems who have had pelvic radiotherapy, and that sort of kick-started the whole survivorship agenda at the Christie. On the back of that, we did a strategy for survivorship, which we took to board in 2012, which some of you might have seen. And one of the things in there was around life ahead planning, and this was a document that started to be devised around that time. But it became very clear to me that what we really needed to make the life ahead plan work better was patient involvement and patient contributions. And that's when Sue and the patient reference group got involved in developing the life ahead plan to great effect, in my opinion, to make it much more patient friendly, and also to create a sense of something that's buy-in for patients. So it's that sort of sense of peer support, the sense of the right sort of language being used, so that it's crystal clear what we're trying to get at, and also the reassurance that it's okay to ask certain questions that might be bothering people as they go through the early and later monitoring stages. Do you want to add anything to that, Sue?
No, other than that, although it looks finished, it's never finished, because we're always looking to improve things. And this took, I don't know how many draft versions to get to this, but no doubt when it gets out in use and gets out amongst lots of people, there'll be more changes as well. So it's as much a document for the people to use as they wish and suggest changes, and you may also want to suggest changes as well.
Thank you, that's great. Why did we develop it? Okay, well, I've put on the sheet here that we collected formal and anecdotal feedback from patients. Well, that's conversations with patients that we've had over the years. And the phrase that crops up time and time again is this idea of falling off a cliff after treatment, the sense of isolation. They're not coming back to the Christie for regular treatment. They might have been on radiotherapy or chemotherapy. They're coming in all over the place. And they're so used to coming in because it's such a long-term issue that all of a sudden that stops, and they think, well, hang on a minute, what on earth do I do now? I haven't got another appointment for, X number of weeks. It might be a telephone-based follow-up, for example. It's a real change from coming in and receiving the treatment that they've had. So we needed to address that, and one of the drivers, for example, in the Oak Road Treatment Centre was a patient experience questionnaire, where one of the questions was about, did you feel supported after you'd finished your chemotherapy? And the answer was, well, no, not really, because I felt like I was just sort of floating back in the community with no real direction. So what we hope we can achieve by introducing the Life Ahead plan is a sense that patients still feel supported when they've finished treatment, but more than that, it's to promote this idea of supported self-management. So what we're not doing is handing over a load of patient information resources and saying, this is what you need to do. What we're doing is we're handing them a structured, essentially, care plan / questionnaire, which is helping them formulate the questions that are important to them, so that they can start to take control over their life after cancer and what's meaningful, and identify those areas that they need help. So we're not spoon feeding patients here, we're helping patients to help themselves. And this is really, as you remember from the recovery model, the mentality that surrounds the whole thing. So your health and well-being event, for example, is also about promoting self-management. It's giving people an opportunity to self-refer to services that we may have assembled in a marketplace environment that people can go and visit and talk to and put themselves forward to join. And again, things like the GP cancer care review would be much better served if the patients are going in there and contributing rather than just expecting a sort of a review to take place, an assessment to take place. They're coming in there with questions formulated and a sense of where they are in their life at that moment. And really, when we consider the numbers of people who are going to be on cancer follow-up pathways in the future, you've seen the statistics already in this session. There are going to be huge numbers of people in the early and later monitoring stages that we currently don't have. So to have all those people coming in through the door using the traditional follow-up pathways that we've currently got is going to be untenable in about 10 years' time. So we have to look at changing the way that we deal with patients, and we have to look at managing patient expectations around what supported self-management means. And what it doesn't mean is kicking them out the door and saying goodbye. It's not a different way to discharge people. It's about offering support, but doing it in a structured way that allows patients to keep control and make decisions for themselves. Does that make sense? Because that's really fundamental to this.
Is this just for adult patients or children?
I'll come on to that. There's a little section here about how it fits into the recovery model, but I think that's fairly obvious, and we've probably covered that already. Those of you who are familiar with the recovery model will know how that works. But really, it's tailored to work with the treatment record summaries. A lot of the answers to the questions, particularly in the blue and purple sections in the Life Ahead plan, would be in a treatment record summary or a letter to a GP. So that's where I'd expect a lot of patients to find that information out. And in an ideal world, those documents would be probably delivered around the same time as a Life Ahead plan is introduced. We're probably not there yet, but that's fairly aspirational. I'm not going to go through the testing and piloting bit, but if anybody is a sucker for audits and surveys, the information's there. I just wanted to demonstrate that we have gone through some testing and piloting. I'm not just throwing you a document that, you know, no patient's ever seen. So there has been some work done on that. But again, as Sue says, you know, we're not adverse to making more changes, more improvements to the documents as we get more information about how it's being used in different settings. And this really is a fundamental point as well. The Life Ahead plan is not just something that you give out in one place at one time. And I've come up with a few possible options for how you could use the Life Ahead plan. And really it's down to you guys, because you know your clinical pathways better than I do, about where you think this would best fit. But here are some options that I think it'd be worth thinking about. This is on page 3. It says the Life Ahead plan can be used in the following settings: on a one-to-one basis with individual patients and or a carer or family member, with the undivided attention of a clinician helping, which most likely is a CNS, AHP or radiographer, or perhaps distributed after the penultimate treatment session has been completed, you know, either chemo, radiotherapy, or even after surgery, potentially. And really what's that saying there is it's okay to use the document as an aid, perhaps in a follow-up appointment, or, you know, with the help of a professional. That's one potential scenario. But I'm very, very aware of the fact that, you know, we do have a limited amount of time with patients as they come through follow-up, and it may not be possible to do that. So the second scenario is around the plan being completed by patients on their own, in which case you do have to make sure that the appropriate information is available to patients to look at when they're attempting to fill in the plan. Now, it doesn't have to be just dumped on them in a massive pile. It could be done in a phased approach, or it could be done by pointing them to the website, and there's stuff on the back that I'll go through at the end, which is where you can find out information and point patients to. But really the point about having the patient-friendly language and the structured Life Ahead plan with the 3 different coloured sections is to make it as easy as possible for patients to have a crack at it under their own steam. And again, it's about managing the idea of supported self-management and bringing the idea that, you know, you can do something to help yourself. Use this plan as a basis to formulate your ideas, you know, and take it forward and tell us what you need. That's really the thinking behind that. So people can go home and use it. That's again facilitated by the appropriate clinical teams, CNSs, AHPs, radiographers. You know, I think it's got potential to be used in all of those areas. And finally, the plan could be used as a tool to facilitate group workshops. Now, we had Louise Pennington with us for the first session today, which is set to go off to the MRI. And she's actually tried to use the Life Ahead plan in a group setting with teenage and young adults. And she had great success at exploring potentially very difficult issues with a group of 3 girls in her area. And I'm just trying to think, there was 2 with Hodgkin's lymphoma and 1 with ovarian cancer, I think. So some of the issues that came out of using the Life Ahead plan were body image. You might have to help me out here a little bit.
Body image.
And sex.
Issues,
Yeah. These are very difficult things for people to talk about, perhaps on a one-to-one basis with a nurse. You know, it may be that sort of relationship hasn't been explored. But in this setting, it was the peer support really that allowed them to start talking. And once they identified these issues, all 3 of them said, well, I've had a similar experience. What they didn't like about the Life Ahead plan was actually filling it in. So I think when you're using the Life Ahead plan, there's no expectation that this is homework. I'm going to mark it next time you come in to see if you answer the questions right. That's not what it's about. It's about people using it to prompt discussions, to formulate questions, and to bring back, you know, what's useful to them. And again, it's basically person-centred, isn't it? That's the ethos behind it. But once again, it does bring me back to the idea of supported self-management, because again, it's about people thinking and reflecting and coming up with their answers to the problems that they might be facing, and identifying ways that they can get support without it being spoon-fed by the professional. Does that make sense so far? So it may well be that you've got ideas in your own areas for where you could use the Life Ahead plan in any of those 3 ways, or possibly new ideas. You know, quite up for people to have a go at anything, as long as we can justify it in the framework that we've described.
And
And
you get a sense for the
We haven't explored that. I'd have to ask Louise. My gut instinct would be that, you know, if it was online, it might be friendlier for younger people. But having said that, I would like everybody to be doing it online eventually as an electronic document or on an iPad or something, because it's absolutely perfect for that. And there has been some movement with the informatics team around patient-held records, but I don't know how far away that is. And really, at the end of the day, what we need to do is to start using something so that we can start getting the wheels on the recovery model as best we can. And then if we can demonstrate that things are working, I'm sure we can start to encourage IT to put that particular project a bit further up the agenda. Because I would love to see it done as an electronic document, and it'd be much quicker as well. You know.
She did say though that even though there was the initial a booklet, paper, pen, that once they'd looked at it and started talking between themselves, that they really did get a lot from the conversations they were having. So, yeah,
it's great.
Online would be great eventually, but they did get over that barrier, even though they didn't like it to start with.
So those of us who are doing the men's cancer event on the 20th of November, the intention is to use the Life Ahead plan at the start of that day with groups of 5 guys, and use that in the same way that Louise has used it with her TYA people. So we will need to have a serious chat about doing that and how it's going to work, and we'll use Louise's experience to guide us. I think I'm looking at James. I think you're going to be involved with that, and various other colleagues as well. So I'm enthusiastic that will give us a lever to get people, particularly men who perhaps haven't thought about some of these things, to get them engaged with dealing with some of those holistic needs, some of those healthy lifestyle concerns, and then when they do go into the health and wellbeing marketplace, they'll already have in their head, oh, my concerns are X, Y, and Z. Perhaps I'll go and speak to personal trainer X or smoking cessation officer Y, and you know, that sounds ideal, doesn't it? But we'll have to see whether that works or not. Elements included in the Life Ahead plan. I think I've covered most of those. I'll just tap my nose and say that the blue section and the purple section are to be filled in around the end of treatment or shortly after the end of treatment, and the red section is to be filled in 12 to 18 months post-treatment. So clearly there's a big gap between filling in the purple and the red section, but they are not too specific, and really at the end of the day, if it feels like a good idea, it's probably time to fill in the Life Ahead plan, or at least have a look at it. So again, let's keep it person-centred, let's make it individual for each patient. And they hopefully will prompt it, because if we use the right language around self-management and around helping us to help you, the prompts to look at the Life Ahead plan will probably come from the patient and not necessarily from us. Just a few key concepts just to make sure these are all in people's minds as well. These are all about really where we are at the Christie with the survivorship agenda at the moment. Your life ahead, what does that mean? Well, it refers to the process by which recovery after cancer is sustained and patients begin to stop seeing themselves as patients or survivors. That's the concept there that's worth bearing in mind. The new normal is a phrase that crops up in the Life Ahead plan quite a lot. That's one of our little buzz phrases as well. Now this is about patients reclaiming or revisiting aspects of their lives that they might have done before a cancer diagnosis, that's been affected by a cancer diagnosis, that they might want to revisit afterwards, but it will be different than how they used to do it. So that could be a sporting activity, it could be anything you can think of, you know, an activity, a hobby. It could be about mobility, it could be about diet, it could be about it could be a new activity that they've never tried before. But what we're doing is we're creating a new sense of self post-cancer, which is reflective of the person who was pre-diagnosis. So it won't be the same, but it will become the new normal, it will become the new person. That all sounds very psychological, so I hope that the psychological people who are amongst us are nodding in agreement. Are you?
Absolutely, Ben.
Would you like to add anything to that?
I think it's inevitable. I think everybody needs to. Everybody's finding their new normal, so it might be activity focused, but I think it's primarily people's sense of themselves because they're affected by having been through cancer. So I think, and kind of as a tool with people, when we begin to think about the new normal rather than getting back to normal, that's when the process of recovery, if you like, and living with and beyond is
That's a good. Yeah, I totally agree with that. Anybody not know what late effects are? Because otherwise we're going to assume we're all au fait with that one. Brilliant. And supported self-management, I've waffled on at length about, but that really does underpin the whole thing. Now, hopefully this little bit section at the end will be useful to you, and I'm thinking really in terms of, okay, so I'm now using the Life Ahead plan and patients are asking me questions, what on earth do I do? Because one of the barriers towards doing holistic needs assessments and using things like the Life Ahead plan is it a can of worms? Am I going to start to get asked questions I don't know the answer to about all sorts of stuff? Well, the answer is there are going to be questions, but you'll be pleased to know that there's a whole range of people who can help with this, and it doesn't all fall on the shoulders of, you know, a TNS or an allied health professional, whoever it is. There are people out there who can help. So, for example, if there's a question that crops up about employment, finance, benefits, legal stuff around work, getting back to work, it's Richard Hunt, who works for the Shaw Trust / Macmillan / the Christie. I'm never quite sure where he sits, actually. But he is in the office next to the Cancer Information Centre, where he actually literally sits. And he can be contacted on that number, and you can give that number out to patients as well. So that's a great source of advice available to patients there. And there are loads of issues around work and finance that crop up all the time. It's such a big hitter. He's absolutely, you know, he's snowed under with people, but he's doing a great job, so he'll be able to help you out with that.
Sorry, Ben.
Hi.
I'll probably touch base outside of this meeting.
Okay.
As I said, I'll be involved in protons, which will be a national service,
Yep.
so it's going to be a bit of a problem in terms of getting patients out of region.
Well, what we need to be doing there is linking with Macmillan, and I've got loads of contacts around the country from doing the conference, so we can identify which region they're in. I can get onto the survivorship lead, and we can work out some pathways for you. It's a very good point, but actually we are quite well served here for national contacts at the moment, and I would expect by the time you get up and running with protons, well, exactly, we'll be well on the way to having a national network around this sort of thing. And the other thing to mention about that is the fact that if we are serious about the recovery package, then it's going to end up being something that specialist commissioners and local commissioning arrangements will need to accommodate. So you will find that if we're serious about having health and wellbeing events with a marketplace of services, then the menu of community-based services will have to be embedded into proper commissioning, as opposed to it being fairly piecemeal wherever there's projects going on like it is now. And that, I think, would be a very serious change. Be difficult to do. I also think they're underestimating how much that might cost, but that's a whole other issue. Don't go. You've got to fill that in before you go. Sorry. I'm going to finish really quickly because we're probably out of time, aren't we? What time are we? Oh, we've got 2 minutes. Great. We've got smoking cessation, complementary therapies, and acupuncture from the complementary therapies team. They welcome referrals and have drop-in clinics, and some of them are here.
There's an E in the word, that is, rather than an I.
What's that? Complementary. Complementary.
Although it is free.
Okay. I'm coming for a massage later anyway. We've got the memory clinic, which Jonathan Parker runs in the conservatory on a Wednesday, which we can get patients to go to if they have issues around memory, and you can advise on that, can't you, as well?
Yeah, whether it be kind of chemo-related or radiotherapy-related memory problems, or people are struggling with memory and need a little bit more assessment, perhaps.
Not the menopause, no.
No, although, well, I sit next to him, so I just get one-to-one advice.
Okay. And very quickly, we've got Ali Davenport's service, Manchester Health and Wellbeing, based in the council, who welcomes patient referrals, particularly useful if they're no longer on follow-up, because if they're no longer on follow-up at the Christie, you have to essentially refer them back to their GP, which isn't ideal at the moment, but that is the situation. But someone like Ali Davenport can fill in for the sort of things we think the GPs probably aren't very good at picking up, and you know, it's a great service, and I strongly advise you to get in touch with them and find out a little bit more about it. And very, very quickly, we have the Living With and Beyond Cancer website. You'll have seen these little URL cards. Please give these out to patients. They're very useful. They'll sit in patients' wallets until they need to have a look at it. And it's virtual peer support is the buzz phrase for the website. You can log on, you can hear stories from other patients. It's all about narrative. It's all about legacy. It's all about coping mechanisms, that sort of thing. And if we have anybody who's specifically having issues with pelvic radiotherapy, and bowel problems or urological problems post-treatment. Sue runs a support group every month for those individuals, which we're very happy to accept new people onto, and has proved to be very successful so far, so please bear that one in mind.